Combined contraceptives, of course, this is one of the most important subjects we meet for the time being, and it's very important and need for contraception. Regarding hormones, it's one of the most important methods of contraception. The history of contraception is very important, as fertility control is as old as men and humankind. It started with embryocide and abortion, where the method of choice in the primitive societies. Condom appeared during the 16th century to protect from sexually transmitted diseases. Spermicide and the use of vessels introduced for commercial use in the 19th century. Richter introduced thread vessel and Grafenberg used the copper-made intrauterine ring few years later in the 19th century. The pill, as we can see, we started from 1955 to 58 with field trials in Puerto Rico until 1965. Early United States field use has risen from 500,000 women in 1961 to almost 4 million in 1965. The pharmacology of the pill is very important. We have estrogen component and the progesterone. Estradiol developed by adding estradiol group to the 17th position of estradiol. It was inactive orally, then became active after adding this estradiol group. Mestranol converted into estradiol in the body. Also, it was given orally. All low-dose pills contain estradiol because it's not very expensive. Metabolism of estradiol varies from female to female and available in the same female at different times. This explains differences in side effects from a case to another. Thrombosis as a side effect is dose related. 20 to 35 microgram is still the safest. 17 beta estradiol and estradiol valerate show minimal effects on liver enzymes, which means no DVT. So we can find it in progenova 2 mg, cycloprogenova, estradiol valerate, norgestrel, and we have to keep in mind it's expensive slightly, so it's not added in the usual contraceptive pills. The progesterone component, we have the progesterone, synthetic progesterone, and progestins. The classification of progestins, these are the synthetic. We can have to keep in mind, starting with C21 progestins, this is perineal nucleus, 19 nortestosterone, this is comes from estrogen and hormonal nuclei. Then we come those coming from spironolactone, which is drospirenone, the unique one, and which have anti-androgenic function. And we have, of course, from the C21 progestin, the cycloterol acetate, which has also some anti-androgenic function. The new progestin include desogestrel, gestodine, and norgestimate. And we have to keep in mind the newest, the drospirenone, which come from spironolactone, had a strong anti-androgenic function. The increased sex hormone binding globulin, decreased free testosterone, do not affect cholesterol. The slight decrease in absolute risk in DVT with drospirenone, gestodine, and desogestrel compared with levonorgestrel is extremely low for all contraceptive pills. So the evidence is not compelling enough to change the prescribing pattern as has been tried by others. The mechanism of action of contraceptive is known, very well known. We have a gestational agent that has a value. Estrogen suppression of FSH has a value. Estrogen stabilizing endometrium, progesterone made endometrium non-receptive to ovum implantation. Monophasic versus multiphasic cyclic or continuous use. It depends on the patient, and we have to make individualization. The monophasic or multiphasic, monophasic as a beginning are easy to use with consistent hormone dose that improve adherence, a key component for effectiveness. This is very important for effectiveness. While multiphasic pills require more careful adherence to a specific sequential order. Any change in sequential order might lead to blood coming out or doesn't lead to good cycle control. Multiphasic can be changed to continuous or extended cycle use. Of course, we have to use multiphasic for 21 days. But monophasic can be used for longer time, although supporting data are limited. Changing hormone level in multiphasic could exacerbate mood symptoms in susceptible women. Keeping in mind, usually it's mentioned it doesn't affect the mood, but you can see many patients affected. Cyclic pills, we can use it extended cycle or continuous use. Can we use it for extended cycle? Yes. Patients should be queried regarding achieving the frequency of withdrawal bleeding they desire. Someone is traveling for 3 months and she doesn't want the cycle to come, so she can't take the pills for 3 months. Some may prefer monthly withdrawal, and the other, but the longest time is 365-day formulation with no withdrawal bleeding. Of course, monophasic is a choice in such case. Oral emergency contraception, we have either ulipristal acetate, this is more pregnant, 30 milligram up to 5 days after unprotected intercourse, very effective pre and post, with affecting LH surge. Levonorgestrel oral 1.5 milligram for up to 72 hours after unprotected intercourse before LH rise. So, ulipristal can be taken before and after LH rise, while levonorgestrel before LH rise. Mifepristone 10 to 25 milligram is available. It's well studied and effective in this dose range, like levonorgestrel. Combine E2 and levonorgestrel pills using a method 100 microgram of cyanosolidol and 0.5 milligram of levonorgestrel, or the equivalent 2 doses in 12 hours, less effective and more side effective than the others, and may be followed by some bleeding. This is showing how the mechanism of action of oral contraceptive regarding areas of the body, starting from suppression of ovulation and making inability for implantation. Some drugs interact with pills and decrease its function. Drugs that stimulate liver enzymes can decrease the contraceptive pattern and lead to increase in FSH and LH level. We have carbamazepine, the antiepileptics, oxycarbamazepine, tobrimate, brimidone. This all decrease effects of contraceptive pills, and the contraceptive pills affects its metabolism. We have the felbinate, the phenobarbital, the rifampicin, and the rifabutin, levirapine, and phenytoin, and all antiepileptic drugs affected and affect contraceptive pills. Drugs interact with pills like containing potential action of diazepam and chlorodiazepam, librium, tricyclic antidepressant, and thiophanate. So we have to measure the level during use of contraceptive pills. Lower doses of this agent may be effective in pill users. Large doses of acetaminophen and aspirin are needed in pill users due to influence on clearance rate. They increase its clearance. We have the medical eligibility criteria of the WHO. We have 4 categories. We have category 1, no restriction for use in Latvia up to 40 years. In Leprous, we have unexplained vaginal bleeding after evaluation. It can be used in HIV and TB, schistosomiasis, hepatitis, iron deficiency, anemia, thalassemia, and many others can use it. Also, ovarian cancer can be used, and in endometriosis or fibroid. Category 2, this is a benefit over Y risk, the female over 40 years and those containing drosprenol and 30 to 20 microgram of estradiol, obesity, body mass index 30 or more, family history of DVT or pulmonary embolism, superficial thrombophlebitis. We can hear why the risk against benefit ratio, surgery without immobilization for a long time, and extended amenorrhea and other many diseases. Category 3, here the risk will outweighs the benefits, and it's better not to use it in cigarettes, smoking less than 15 per day, in female more than 35 years old, postpartum less than 21 days or 6 months in lactating women, history of oral contraceptive induced cholestatic jaundice, mild compensated cirrhosis, also for previous breast cancer with no evidence for 5 years, migraine without aura over 35 years, and so on. Category 4, we we mustn't use contraceptive pills in such cases. Valvular heart disease with thrombotic complication, coronary artery disease, stroke, diabetes with vascular disease, hypertension, cigarette smoking in women more than 35 years, high risk personal history of thrombosis, and many other factors like migraine, headache, and with localized neurological signs, and so on. To overview contraceptive pills, it's highly effective. Failure rate expected less than 0.1% and typical 7.6 in the first year of use. Convenient, most common method, reversible. It's safe in those who are exposed to DVT and embolism. Few intolerable side effects, limited contraindication. Have a lot of non-contraceptive value. Can we use them for non-contraceptive value of pills appear in cycle-related benefits? Controlled cycle, decrease blood, possible health benefit, decrease appendicitis, less anemia, less symptoms of polycystic ovarian disease, less benign breast distension, and so on. Other possible health effects: stop ovulation in patients with bleeding tendency to prevent intrauterine bleeding and ovulation, like those having, for example, decrease in platelet function, those having decrease in some factors for ovulation. Pills can decrease the rate of intrauterine bleeding. Pills protect against endometrial cancer and ovarian cancer, decrease risk. Cervical cancer is controversial. Some say it helps in bone mineral density, and some say it doesn't help, but it might help in maintaining bone mineral density. Specific symptoms: acne. Many combinations improve acne, especially those including sibutolone acetate and drospirenone. Also hirsutism. Dysfunction, uterine bleeding improves in 3 cycles. Menstrual association symptoms like premenstrual PMS and PMDD, premenstrual dysphoric disorders, and dysmenorrhea improved in different levels. Benefit decrease, as we can see, ectopic pregnancy rate with 90%, ovarian cancer with 40%, and many other cancers also can be decreased. Ovarian cysts can be decreased. Fibroids after 5 years of oral contraceptive use decreased by 15%, menorrhagia and other things, especially also dysmenorrhea. It is safe for a young woman to be on the pill than to become pregnant. 2 per 10,000 risk for venous thromboembolism of users in age reproductive period, meeting 20%, 20 per 10,000 during pregnancy means it's helpful in prevention also such disease. Recent contraceptive options: pills containing drospirenone, 24/4-day regimen. This is very important also. Novaring, which is applied inside the vagina, and also Ibra, which is applied on the skin every 7 days for 3 weeks. New contraceptive options regarding drospirenone, as mentioned, with its values as anti-androgens and many things. New contraceptive options at 24, it contains least amount of estrogen. The vaginal ring, with nothing stated orally, that it's applied to the vagina for 3 weeks use. It was not popular in many areas. Then we have to go to the ortho Ibra from Janssen Select, delivers 20 microgram isoniazid estradiol and 500 microgram norgenestromine. And this is 1 patch every week for 3 weeks and 1 patch every week. The future prospects of contraceptive pills: we think we have to decrease estrogen content to decrease side effects, or change the kind of estrogen from estradiol to estradiol valerate, apply new estrogens, anti-androgenic, natural progesterone or several, but the natural progesterone are more expensive and difficult to be put in pill users. Patching, nasal, post-coital local or patching, and it mustn't affect libido. Thank you.